think there are 3 points that I'd want to make. First, borderline personality disorder in adolescence is a must as a diagnosis. Not making that diagnosis is betraying children and young people who are actually suffering, and we understand why they're suffering and understand how they're suffering. Second, we know how to help them. We know how to help them at the moment to a limited extent. But I think we understand so much, and that's my third point, we understand now so much about the reasons that they are suffering, that for us not to develop the treatments that we need to develop to help them even more would be abandoning our professional responsibility. Well, we now know that actually improving an individual's capacity to organize their emotions and to understand their own feelings and the feelings of others better actually makes a difference to that individual in the long run. The reason for that is that they come to relationships without understanding others adequately. They find those relationships more troublesome than the rest of us do.
So the therapist should step into their shoes and try to understand their perception first.
This is the bottom line. Unless and until we get to a stage where we can really properly understand these individuals, not in terms of what they're doing to themselves or to others, but actually how they see the world, what it is that they are experiencing, setting aside some of the behavioral problems, not worrying about our own anxiety in relation to this problem quite as much as we are at the minute, but instead to adopt their position and look at the world, see where they are. If we can see where they are, they will respond to that and they will listen to us better. I think that sometimes when these individuals are with us, we adopt the wrong attitude. We are too likely to be integrated into a system that's maladaptive. We start worrying, we get anxious, we do risk assessments, whereas what makes a real difference is to concentrate with them on what is positive, what they're doing right, to strengthen their resilience and to actually enable them to cope better with the ordinary stresses and strains of adolescent existence. I would not want the therapist to be patient. I want the therapist to be impatient in terms of be impatient to try and help the young person. But I don't want the therapist to be helping themselves and reducing their own anxiety at the expense of the young person. So to engage with the young person where they are is really the critical message here. This is one of the best places to keep your knowledge up to date, and I would strongly encourage everyone to do so. But I think I would even want them to think about progress when they are no longer here, when they've gone back to the consulting room, because that's when I think the problems really start. We all like doing what we know how to do. Mm-hmm. I think the problem for most of us is that when new things come along, we take that on board if it fits with what we've been doing already. If it requires us to change and to think differently and practice differently, we have much more difficulty. If we would be more willing to play with ideas, play with practices, try things out, actually explore the world of pathology in an evidence-based way, but actually in a systematic way, that is, in a systematic way, explore what has been shown to us in playing manipulative. Can I try something new? Can I try something that's different from what I've been doing? Would it be fun to do this? Would it be fun to try to do this? And I think that is the attitude, that's the kind of inspiration that I would like people to take from a conference such as this.
Dare to experiment?
Dare to experiment would be a wonderful way of putting it.